Great. Okay. Well, I'm going to let folks get settled in. Good morning or good afternoon, depending on where this broadcast finds you. We'll let folks get settled in, and then I'll let Cam get the introduction started here. Great to see some familiar names and faces. Feel free to turn your camera on. We'd love to see you on this great Wednesday. October Wednesday. There's Doug. See, I knew I'd see at least one face in the crowd there. Doug. And we've got a few others, Cam, just connecting to audio. Let's give them a chance to get plugged in, and we may have some that are coming in a little later as well. But I want to thank everybody for taking the time out of your schedule to join us. Hi, Mabel. Glad you could join us there. Hope the weather's holding in New York.
Weather's been better.
Good. That's good. In Iowa, this is the best weather we get. We get about 6 weeks of Northern California weather, and then it goes away. Cam, I'm ready whenever you are.
Okay.
We'll get started.
Hello, everybody. Welcome to the ESAS Clinical Evaluation Screening webinar that we have today. I'm Cam Marcingill. I am a communications team member with the Native Center. All right. This event is brought to you by the National American Indian and Alaska Native Addiction Technology Transfer Center, which is located at the University of Iowa, and we are part of the National ATTC network. This project is supported by SAMHSA. The content is developed by the presenter, and the opinions expressed do not necessarily reflect the views or policies of SAMHSA, HHS, or the American Indian and Alaska Native ATTC. Following today's event, we will send out a follow-up email, which will include links to the presentation slides and recordings, and if applicable, information about how to request and receive CEUs and the link to our evaluation survey, or GIPRA. At the end of today's event, we will also share the link to our evaluation survey in the chat box. The survey is very important for our center and our funders to ensure that our events are beneficial to those who attend. Your participation is voluntary, but we would really appreciate you taking the time to help us by completing the survey. You may skip any questions that you do not want to answer, and all responses will be kept confidential and cannot be linked to you. Please reach out to myself or any of our staff if you have any questions about these surveys. So although we are gathered virtually today, we want to take the time to acknowledge the land and pay respect to the Indigenous nations whose homelands were forcibly taken and inhabited. Please take a moment to read this land acknowledgement, which was created by our 3 staff members on our team, Ella and Keely Driscoll and Sean Bear. And today's speaker is Stephen Steiny from the project manager at the National American Indian and Alaska Native Addiction Technology Transfer at the University of Iowa and the College of Public Health. Steve earned his bachelor's in communications in 1994 and his master's in substance abuse counseling program in 1997 from the University of Iowa. He has been is a certified alcohol drug clinician with the state of Iowa since 1997. He was born and raised in Iowa and has worked in behavioral health services and a nonprofit sector for 23 years, providing both direct patient care as a clinician and provided supervision as a clinical manager. Since January of 2019, he has been working for the National American Indian and Alaska Native ATTC at the University of Iowa. He has been in recovery for over 34 years and committed his life and profession to helping those in the recovery process.
Well, Cam, thank you for that introduction. And yeah, I threw in the chat that I was 35 years on the 19th of September. So it's been a wonderful journey, and I've had a lot of help from a lot of people. So I only take a small credit for that. Really thrilled to have you all here this afternoon or this morning, depending on where you are in the country. I'm going to pull up the slide deck for our presentation today. We are going to be talking primarily today about a portion of the clinical evaluation process, a very important part, which is screening. And we're going to share a lot of information with you today. And this is an essential part of the evaluation process, as many of you know. And this is an ongoing series for those of you that are joining us perhaps for the first time. This ESAS is the Essential Substance Abuse Skills Training. It's really rooted and connected to the 12 core functions and the 46 global criteria that exist and that we find in a lot of the certification and licensure processes regarding working in the substance use disorder field. So that's really where this curricula and information is derived from. I come from a clinical background, as Cam mentioned, and spent many years working in a clinical substance use disorder facility. And so a lot of what I'll share today is we'll share some experiences that I've had as a clinician, but also share with you a lot of other information connected to this topic. So I'm going to pull my slides up here. Let's see if I can do this without breaking anything. And if I do, Cam is there to help me. I've been known to break Zoom once in a while. So let's see if I can get the right screen up. Cam, how does that look? You guys seen the full screen or you seen the note screen? Full screen?
Full screen.
Oh, that's great. Great. See, I didn't break it, everybody. Small round of applause later. I'll take it. Yes. So again, I just want to welcome everyone to this installment of our Essential Substance Abuse Skills Training. I'm really happy to have you all here with us. And as Cam mentioned, we are going to offer 1.5 continuing education units for this training. You can request those in our email that we send out to you post presentation today. Those are NADAC approved, and you can use those with your licensure or certification body in your respective state. So happy to have you here. This is just a kind of an introduction and overview of what I'm hoping we can touch on today. We're going to go through these slides fairly quickly. Cam and I will watch the chat box. You're currently muted, but if you have a question or want to use the hand raise feature or utilize that chat feature, and we'll either stop and kind of address that as we go, or perhaps we'll wait till the end if we have a chance to take some questions at that point. So here you can see some things. We're going to try and really take a look at the screening process for patients with alcohol and other drug use disorders. And again, to keep in mind, this is the first step in this process. Sometimes I think of screening as a brief sort of rule out as well. It can be a way to rule out the presence or existence of a substance use disorder or assess risk factors for future problems. And it also, we're also going to talk about the next step is in the process to really sit down and interview the patient to determine whether or not there is present or a potential substance use disorder that may be there. And then we're going to really take a look at the sort of the progress through material in the following order. So we're going to try and look at sort of this process and the materials. So we're going to look at some screening tools that you might use, but hopefully we'll get a chance to go through a lot of these. And this is something I want you to keep in mind as we go. And those of you that are practicing in the substance use disorder field or related behavioral health field, I think this comment or this idea will resonate with you. A patient's substance use is not the problem. It may be causing them problems, yes, but rather it is a symptom of underlying issues that may be the cause of why that person started using in the first place. So let's keep that in mind as we go through and begin to dismantle the evaluation process. We're going to talk more in depth about assessment next month, but this is the lead in. This is talking about screening, that initial process of ruling out or identifying risk factors. So if we look at clinical evaluation and screening, these are some of the things we're going to try and look at. We're going to look at the stages of change. We're going to look at and talk a little bit about why people change, what factors or what things to consider when we think about change, especially with our patients. We're going to look at some brief intervention for alcohol issues, frames. We're also going to look at the difference between screening and assessment, because there's a distinct difference. And those of you that are familiar with this process or this continuum will understand this. And we're going to look at screening for substance use disorders. Hopefully take some questions and comments, and also look at the DSM-5 components. Hopefully, if we don't run out of time, I want to at least look at some of the criterion for determining substance use disorders in the DSM-5, and also some treatment options and different modalities. It's a lot to cover, but let's see how we do. So in the late 70s and early 80s, the stages of change were developed by Prochaska and DiClemente. Initially, they were really designed to address assessing a person's readiness to quit using or smoking cigarettes. And it really examined those who needed more treatment versus those who were able to kind of quit using cigarettes on their own. That was sort of the inception of this idea of the stages of change. So let's take a look at these a little bit. Just maybe a show of hands quickly. How many of you have utilized, or your agency is utilizing, some version of the stages of change? Anybody? I see a few hands popping up there. And if not, that's okay too. You might see some familiar components to this as we go through and talk about this. And I think there are also some sort of foundational elements that you might just naturally address when assessing your patient's readiness to make changes regarding, in this case, their substance use or related behaviors. So this is sort of, we're going to break these down, but Think of this as it's sort of in a circular, we'll look at kind of a circular model to this, but think of this as in the beginning, a pre-contemplative stage, all the way through to perhaps a setback or some kind of relapse, and then restarting these stages, and then reaching sort of an endpoint, at least in their primary treatment care, of some sort of graduation or completion. So let's look at these. And for those of you that are utilizing these, this will be a refresher. And I would encourage you to also throw comments or thoughts that you may have about your experiences in using stages of change. But let's just quickly kind of look through these. Pre-contemplation. Now, in the old days, what did we used to call someone in a pre-contemplative stage? What would we say? We would say, well, they're in denial. They don't recognize or understand that there's a problem, and they're in denial. Nowadays, the sort of the more modern term for identifying someone who is not ready to change would be someone in a pre-contemplative stage. In other words, there's no reason for me to change because there's no problem. In the old days, again, we would say, that person's in denial. Contemplative stage, they're beginning to at least look at the possibility of change, but they still may be very ambivalent about making that kind of change. In a preparation stage, they may be gathering information or beginning to formulate to make an informed decision about what change would involve. And then in the action stage, they are putting that preparation or plan into action, or they're applying it. Oftentimes, when I was working with patients, they would immediately say, "Well, I'm in the action stage because I'm in treatment." And sometimes we would revisit that and really try and look at truly why are they in treatment? Are they here on their own terms, or was it through a third party? And have them kind of take a closer look at that. In a maintenance stage, this was usually marked at around a 6-month period where the person was continued in the recovery process for at least 6 months. That's not a set, determined time frame, but that was usually kind of a marker that we would use in our clinical setting. And then there was also this notion, and we know that this is also sometimes part of recovery, where there might be a setback or a relapse of some kind, where the person may exit those stages of change and return to an earlier stage or even start over again. And then, of course, the completion or graduation, where they've completed their primary care and maybe enter or step down into a continuing care setting. This would be 6 months or more, or perhaps even approaching a year's time period on that treatment continuum. So readiness to change, again, this I think is just looking at that kind of visual. If you can imagine, you can see the pre-contemplative stage is sort of outside of this idea of a patient considering to change. But again, we know that in a pre-contemplative stage, the patient doesn't believe that there's a problem. So why would I change if there's nothing wrong? But you can see that they would then enter and then move through these stages, perhaps exiting the stages, which is denoted by the relapse and recycle, and entering an earlier stage and coming back around. Yeah, exactly, Miranda. And really the term denial is sort of a shame-based term that we really are trying to get away from now. We know it's a defense mechanism, if we go back and look at Freud's psychoanalytical perspective, but denial is also it can be shame-based. So in the field, we're trying to move away from that term and use more of this language about readiness to change. Hope that makes sense. So let's look at some facts about change, and I would encourage you to, if you want to add some others that I could add to this list, you want to post those in the chat. We could consider adding those. But things that I like to keep in mind is change is a natural process. It's constantly happening in one form or another. Brief counseling or brief solution therapy can speed up the change process by pointing out discrepancies or concerns that sometimes can enhance or accelerate the change process. Things like faith, hope, and efficacy are important elements in change. It helps to have others supporting that or promoting or advocating for change. That clinician, that counselor, they do matter in this process. They really do. How they are connecting, how they're relating to that patient or that client or that relative really does matter, and it can be the real X factor in promotion of change or supporting change talk. And empathy is not merely having had a similar experience. It really goes beyond that. It's about trying to recreate or put yourself in the perspective of that patient, perhaps based on some of your own experiences. And it's very different from sympathy, as we know. One of the things, too, I would ask you to do is just in general, why do people change? And one of the things that I've discovered is, a patient, if I was working with somebody, they usually became at least more ready to change when some of the consequences they were experiencing were being outweighed by some of the benefits or things that they thought were good about some of the decisions or behaviors that they were partaking in. So it really was a chance for them to start to weigh out and kind of do a pros and cons review of their lifestyle choices. And also, people engage in change talk and resistance talk. That's just naturally a part of change. People will justify why they shouldn't change, or they may give reasons why they should. But that's a natural process to oscillate back and forth and have some ambivalence about that. So I want to move into shift gears a little bit and talk about the interview skills, because remember, one of the things we know is the screening process can be kind of an opening to having an informal or formal interview. And one of the keys to this is being able to effectively apply micro-counseling skills and perhaps even some strategies or techniques associated with motivational interviewing. But really, this is connected to that idea of initiating discussions with the patient that facilitate acknowledgement or presence of potentially of a substance use disorder. So let's think of this visually. Let's look at sort of the substance use disorder continuum. And we may have, and I think everyone on the call, I can safely assume we know that millions of people use alcohol or drugs recreationally or in moderation. People have done that for decades. So there are people that their frequency and amount we might identify that as recreational or occasional or moderate use. And then over time, some patients would develop criterion that would have us identify them as having a substance use disorder. And this could be mild, moderate, or severe according to DSM criteria. And if we have time, we'll talk a little bit more about that. But I wanted to put this visual up just to understand that we're talking about with the patient who we're screening, they could be anywhere along this continuum. That's the essence of having a screening tool in place, is to identify or rule out the presence of a substance use disorder. So this is interesting too. Having worked with a lot of people in the clinical setting over the years, a lot of patients, there can be some reluctance to share and be open, and it could be any one of these components. This last statement here, disarming the patient, should be done on paper as well. In other words, think of this as, oftentimes I might point out a discrepancy. If I was doing, we'll talk more about this next month when we talk about assessment and evaluation. But if I'm pointing out discrepancies in the patient's self-reports versus public record or other collateral information, this can be a powerful turning point to maybe help them feel safe or supported to share more information. Again, all four of these we could see in one form or another, in combination with one another, or as a standalone reason for a reluctance or resistance to wanting to share and be open. So when we look at a screening tool in general, this might be a sort of a general statement that you would see. In order to optimize your substance abuse assessment today, or substance use screener, I would probably take substance abuse out again. Abuse and dependence are words that we're trying to move away from because of the stigma attached to those. So it might read, in order to better optimize your substance use screener today, you need to talk about a few personal questions, and then really reassuring them that this information will not be shared with anyone. That's a big piece too, when I was conducting a screener or a formal assessment, to remind them that all of their records are protected by state and federal privacy laws, including HIPAA and 42 CFR Part 2. But it's really important to set that tone early on when you're getting ready to ask some questions that might be uncomfortable or off-putting about in this case, about their alcohol use or their drug use. One of the ways that we can approach this is the use of micro-counseling skills. And Alan Ivey was one of the really creators and founders of this. And he really developed this idea of using micro-counseling as a way to connect with that patient and begin to forge sort of that therapeutic relationship or that counseling relationship. And these skills, can be learned, but I would, safely venture to say that those of you who are listening today, most of you, I think, are probably innately gifted with many of the skills that we're going to review, or you probably would not be in the helping professions that you are. I can remember, taking micro-counseling skills in graduate school, and it was really reassuring to see that many of these skills came naturally to me. But videotaping yourself, having your peers and your supervisor review and give you feedback, it made me much more mindful and aware of how important the proper use of micro-counseling skills can be and how powerful they can be. Interestingly enough, for me, these skills would later play out in the many interviews that I would conduct in hiring new clinicians and support staff. So it's strange too to note that these micro-counseling skills don't seem to work as well on family members. So I want to just make a disclaimer that if you try some micro-counseling skills at home, you may not have the same effect as you do with your patients. But Some of the basic foundational skills involved in effective helping relationships. These micro counseling skills are foundational. They're foundational components on which success of interventions with patients can really be connected to that and depend on that. It can create necessary conditions for potential change to take place. It can certainly act as a rapport builder or creator of rapport between the patient and the clinician. And it also helps establish empathic understanding, genuineness, or what I call authenticity, and acceptance of the patient and the patient of the clinician. It really helps to create and facilitate that safe environment. And I would say that they are a set of verbal and behavioral responses that facilitate the process of counseling, and an alliance that can form regardless of the professional counselor's theoretical orientation. So whether you're Adlerian or Rogerian or psychoanalytic or existential, these micro counseling skills can still be incorporated in whatever therapeutic approach you're using. So those are just some things to keep in mind. So attending and attending behavior. So this is important. Counselors' interest in the patient demonstrated by eye contact, body posture, and accurate sort of verbal confirmation that is congruent with that. And then attending behavior. This could be head nodding. It could be small affirmations. Yes, I see. Or just how you're facing and how your body posture is. But these attending behaviors, it really speaks to this idea of active listening. So that's, these are things that to keep in mind: body language, eye contact, and tone of voice are all elements of attending and attending behavior. Attending skills, good communication involves more than just verbal. There's a lot that goes on non-verbally. Patients rank nonverbal gestures in presentation and body language as the most important piece of building that therapeutic relationship. It always struck me as important. Nonverbal attending communicates your interest, your warmth, your authenticity, and your understanding. And it can include many of those elements that we're talking about. Eye contact, we know the power of this. There can be some cultural components too to consider. So you need to be mindful of making eye contact, when to do it and how to do it, or when not to do that. So there's some cultural considerations, but in general, having eye contact can convey interest and some of that attending behavior, that you're with the patient in the moment and listening. Body position. Again, your body position should convey your interest and involvement. This will assist in putting your patient at ease, and it also helps you establish and set your own professional boundaries. And another component is tone. Emotions are frequently conveyed by tone of voice, and I've always been mindful of this as well. Sometimes if you get a soft talker or someone that's reserved, you can mirror that, and it may help them relax a bit and reduce some of their anxiety about engaging in a therapeutic relationship or environment. But very important. Also questioning. Primary skill that allows counselors to collect important and specific information. So again, asking some open-ended questions, tell me more, make sure I understand this, but having those a flow to those questions. This can be difficult sometimes in a structured sort of screener, unless it's self-administered. But if you're administering the screener, sometimes those questions can seem a little probing and a little more dry or impersonal. But the bottom line is you try not to have this be like an interrogation. That will really not take you very far in potentially gathering some important information as you try to screen and rule out or identify substance use disorder. We all know about open and closed questions. Open questions are good because it really puts the patient in a position to give you a little bit more, not just a few words, but tell you a little bit more about what's going on. And it can be encouraging and allow that patient to speak more freely or openly. And closed questions have a time and a place as well. They can be particularly important during a formal assessment so that you can have some short answers that allow you to get through the process without getting bogged down in a lot of extra information that may not be applicable to the information you're gathering on the screener or on the formal assessment. Let me see. So open questions again. I always caution folks when using why questions. Why questions can often cause the patient to become defensive and feel put on the spot. Leading in nature and often places too much power or too much emphasis into the hands of the person gathering the information. So be careful about why questions, but open-ended questions can really allow the patient to elaborate a bit and give some additional information that you may not gather otherwise with a yes or no question. Again, closed questions do have a time and a place. They generally are used to obtain very specific, concrete information and make sure that we have all the facts straight. But again, if you can have the right mixture and know when to utilize closed questions and open-ended questions in this screening process or in this interview process, that's really what we're talking about here, is trying to find a good balance and contextually an understanding of when to use open and closed questions. Patient observation skills. So again, I think this is so important, and Alan Ivy knew this. Nonverbal behavior is 85% of communication, and that again always stayed with me. That how a patient is really doing, how they really are feeling, can be conveyed oftentimes by them not saying anything. Verbal behavior, keywords, discrepancies in the patient's nonverbal versus verbal. So if I have a patient that tells me that they are really excited about a new job, but they are shaking and jittery, there may be more going on than what they're just telling me. They may have a lot of anxiety that they're just not able to or feel comfortable disclosing, but that nonverbal may give me an opening to say, your legs are shaking. Are you okay? Is there something else that you want to talk about? But they can send mixed messages, contradictions, conflicts, and incongruity. So watch verbal and nonverbal behavior. See if there's a match there or some kind of disconnect. And again, for those of you that are doing clinical work, you guys know this. We see this play out often in the patients that we're working with. So I want to talk a little bit about another aspect of the interviewing process, gathering information, even in an initial screener, using concepts like encouraging, paraphrasing, and summarizing. So the ability to reflect feelings can be a very powerful technique. Reflecting feelings, this is the patient's feelings either stated or implied as expressed by the counselor. So you are either saying, it seems like you are very angry, or you're very angry. Reflecting those feelings back. Feelings of the patient can be, again, nonverbal or verbal. So I can reflect back their nonverbal behavior and look for confirmation with them. Reflecting meaning. This is important. Finding the deeply held thoughts and feelings underlying their experience. Paraphrase is to thoughts as reflection is to feelings. So paraphrasing can be a very powerful way to summarize and to make sure that you heard them correctly. Reflecting meaning can also break down complex behavior into parts. And it's said that you should not just, parrot back exactly what the patient is saying, but you want to try and paraphrase or summate your reflection to see if you've got it right. This was very important in my own early training and development as a clinician. I often wanted to jump to the conclusion and kind of solve things. It's important to make sure that you've got and understand what's happening right, and that you can reflect that back and ask them. Again, empathy, I think, is something that, let's see, I wasn't going to say anything else. Yeah, I think empathy is something that we want to be mindful of. Empathy is a great bridge. It's a great bridge builder into the shared human condition. However, at least, I had to be careful with this because I could also lose sight of my role and purpose as the clinician or therapist. So empathy really is the understanding of what the patient is experiencing, putting yourself in the place of the patient. This takes some skill and it takes some discipline, but done properly, it can really build a deep connection with the patient because they know that you're with them and understand them. And again, sometimes there can be a breakdown with empathy, whether it be due to language or language barrier, cultural differences between the patient and the provider. Let's talk briefly about motivational interviewing. We could spend a whole afternoon talking about this approach, but Bill Miller and Stephen Rolnick developed this approach for engaging with patients. Many of you probably know, or if you haven't heard about motivational interviewing, you've probably been in a deprivation tank for the last decade, because this really is motivational interviewing has become sort of the hot button in the last decade or two in engaging with patients. I always liked using a kind of a Rogerian approach, sort of that patient-centered approach in engaging with patients, unconditional positive regard, and really connecting with them. When MI came along, my clinic that I was working for adapted it as the primary treatment model. and it seemed a natural fit for our patients and for those of us working with substance use disorder patients. So I don't need to go too far into the history, but we know that there's evidence that we know Bill Miller was influenced by tribes in the Southwest when conceptualizing the MI approach to effectively engaging, communicating, and empowering people to make changes in their lifestyle choices. Additionally, MI has been culturally adapted and widely accepted and utilized amongst many native treatment facilities and behavioral health providers across the U.S. This is something to think about. If motivational interviewing is a way of being with people, then its underlying spirit lies in the understanding and experiencing the human nature that gives rise to that way of being. How one thinks about and understands the interview process is vitally important in shaping the interview. So, how many of you, just a show of hands, how many of you are utilizing or some element of motivational interviewing in your clinical work? I would suspect I'm going to see a few hands pop up. Yes, I see Mabel with a thumbs up. I would imagine that this, there's Helena is giving a thumbs up. Again, this is a very has become a very popular approach in engaging with patients, using specific language to empower patients to consider change. And motivational interviewing for me, for me to sit down with a patient and say something like, tell me what it is that you like about using cannabis. Now that, it took me a long time to understand the importance of that question. But that question, if you go back to one of the very first slides that we looked at, where we're understanding that a patient's substance use is not the problem. It may be causing them problems, but it may be an indicator or a symptom that there's something else going on. Now, if I sit down with a patient and ask them, I've looked through your assessment, or your screener indicates you're using cannabis every day. Can you tell me what you like about it? What is this going to do? What potentially may I discover with the patient if I ask this question as an opening question? Any ideas? What have I done by asking a question like that with a patient? Anybody have any ideas? You could unmute, shout something out, or throw something in the chat. Okay, here we go.
This is Mabel. Just like you're just entering their world and just trying to find out positive.
Yes, very, very much so. Removing the negative, Dana says, and establishing trust. Deborah says establishing trust. What was the question? I'm using it as an example question. Tell me what it is you like about your use of marijuana or cannabis. Yes, Kelly. And what this is also doing potentially is it takes me out of the role as the person that's going to make them do something, because MI says it's ultimately up to the patient to decide whether they want to make changes or not. But it takes me out of the role of the person forcing them to change. And it opens the door for us to have a discussion about maybe why they started using in the first place, or what are some of those other underlying issues. Maybe they have difficulty sleeping. Maybe they have some anxiety. Maybe there's some other stress factors that are going on that are really the drivers behind the use of cannabis. I hope that makes sense. Yes, Frank, exactly. That's exactly right. So, if you're not familiar with MI and are interested in that, I would suggest doing a little research on your own, or talk with your program director or your clinical director and see if your agency would be willing to explore and support some trainings on motivational interviewing. So there are countless examples of ways to approach a patient, but you're really collaborating with them, you're joining with them, you're coming alongside them. And rather than telling them how to do things or what they should do, it's really counterintuitive to, the old school approach of I'm going to get in your face and you're a drug addict and you better admit that you're a drug addict right now, or you're not getting out of this program. Wow, did you guys feel like I was in your face there? That's that old school approach. And, I'm not knocking it, but there's those kind of engagements with patients are few and far between. It's patient-centered. It increases the patient's response to screening and assessment and adherence to treatment. It fits very well with harm reduction. Perhaps a patient is not interested in total abstinence. Perhaps we're going to talk about a reduction of their use. I know you're drinking about 18 to 20 beers a day. Would you be willing or consider cutting down to 8 or 10 beers a day? That could be a start. And that could be utilization of and a discussion you could have even post-screening or assessment. We also know that it improves treatment outcomes by enhancing this idea of this incentive to change. Sort of the rationale behind this, again, clinicians commonly think that they are already practicing motivational interviewing when they screen, assess, and treat. And for some of you, some of the components of MI, you may be doing naturally. What makes MI a unique counseling approach is how its skills are employed and utilized. Motivational interviewing requires attention to timing, issues, strategies, and applications in maximizing the effect of these. Again, it's using specific language and strategies to empower the patient to make informed, self-directed decisions about themselves and their lives. And most importantly, to elicit the notion that change is possible for everyone. From a screening context, MI is non-judgmental and often allows the patient to reach their own conclusions about their substance use problems or lack thereof. 2 phases of MI: assist in screening, assessment, and patient change. Again, we don't need to go through these just for time purposes, but think about open-ended questions, affirmations, reflections, and summary. We know this as the ORS. Some of you will recognize that acronym. Strengthening commitment to change. It builds on the patient's motivation and resolve to change. It sounds like your health is important to you. So quitting drinking right now seems like a good idea. This is that change talk the patient is offered, and I'm reflecting it back to them. The basic principles of motivational interviewing, again, are to express empathy, to develop discrepancy. On the one hand, you want to be a good mom and take care of your kids, but on the other hand, you really enjoy going out with your friends and drinking and using drugs. Help me understand how these two can match up. That's a powerful, very powerful element of MI. Rolling with discord or dancing with discord, rolling with resistance. In other words, if a patient's goal is not to be completely abstinent, I meet them where they're at and don't try and force my agenda upon them. This can be tricky if you're in an abstinence-based agency or you're in a situation where abstinence is sort of the key element to them engaging in a treatment service. It also involves self-efficacy and optimism, and avoiding that confrontation. That, you remember, that in your face, that we're trying to pull back from that and stay away from that in MI. Again, just looking at fundamental approach and the 4 principles, just for review. And then this frames intervention for alcohol problems. 6 common elements of brief intervention: feedback of personal risk, responsibility of the patient, advice to change, menu of ways to reduce drinking, empathetic counseling style, and self-efficiency of the patient. I'm not as familiar with the brief intervention, the frames intervention. If anybody else has more information about this, I'd be really curious to hear about it. Yes, thank you, Tracy. Yes, yes. And we also have a consultant through our center who has a native version of motivational everything called the Spirit of Communication, which borrows a lot from MI and incorporates that into cultural considerations. Yes, I can go back one slide. Is there a link? Mabel, maybe we can, maybe you can reach out to Cam and see if we can find you a link. Not sure what link you're looking for, but we'll see if we can help you out. So I want to move into this. This is an important slide for me anyway. I'm a very visual person, and it was important for me to understand this conceptually. And when I've done trainings like this before, I usually will use this slide in the beginning of the discussion. But here you can see, and this will fit well with subsequent ESAS discussions we're going to have next month and the following month when we talk about assessment and treatment planning. But you can see here that the time involved in the screening process can be very, very minimal. And sometimes a screener is 3 questions and you're done. You score it and that's it. But screening is generally time-wise a brief sort of snapshot to either rule out or determine whether further assessment may be warranted. I hope that makes sense. The difference between screening goals and assessment goals. And again, we're going to revisit this next month when we talk about doing formal assessment. Screening designed to reflect the likelihood of the presence of a substance use disorder, whereas assessment is designed to provide a broader range of information and possible treatment options for an identified substance use disorder. I want to reword some of that for future broadcasts, but I hope that makes sense that there's a clear difference between screening and assessment. Again, looking at screening goals and assessment goals. Screening instruments are typically brief, are short answer, and can be administered by the patient. They can be self-administered. They can be administered by a non-expert or support staff, and they are very, very upfront about their intent. Whereas an assessment instrument is oftentimes, I would say 9 out of 10 times more time consuming, can require more complex, historically based information, and can really be more effective if done by an experienced trainer or evaluator. And their intent is not always obvious. There may be questions on there that may not be clear as to why we're asking them. So we're not going to spend a lot of time on these different types of screeners, but I wanted to just give you just a brief taste of the many, many screeners that are out there. I would say the ESPERT is probably one of the more well-known ones, but there are several others that I know different agencies, depending on who you're working with or for, whether you're working for a tribal agency or whether you're working independently as a private practice, screeners can vary depending on which group of screeners have been adopted or implemented into the assessment process for that agency. These are just some examples that I had listed: the cage, the RAPS 4, the mast 2. This is the T-ACE, the tweak, which I don't like that acronym. Here's the ESPERT. Again, this is really a stepping stone to referral to treatment. So it's a brief intervention and really allows the clinician or the person administering this to perhaps get a foothold for making a referral for treatment or further assessment. And it's scored, and you can really, again, you can use this ESPERT as a way to identify whether or not there's a potential presence for substance use disorder. The audit, the alcohol use disorder identification test, is another quick screener that can help determine whether or not there may be a presence of, in this case, an alcohol use disorder, which would warrant further screening and or formal assessment. So I want to just briefly, again, we could spend an entire afternoon talking about substance-related disorders as they are described in the DSM-5. But I want to just give you, again, a snapshot of the different substance-related groups that we see in the DSM-5. They're listed here. Almost all substance-related disorders in the DSM-5 include substance use disorders, intoxication, and withdrawal. There are some exceptions. Caffeine, for example, and all of them also have specifiers for mild, moderate, or severe. There are exceptions. Caffeine, hallucinogens, inhalant, and tobacco are exceptions to these two criterion for substance use disorder specifiers. Alcohol use related disorders include alcohol use disorders, mild, moderate, and severe, alcohol intoxication, alcohol withdrawal, and unspecified alcohol-related disorder. We know this now, the use of the term alcohol abuse and dependence was eliminated in DSM-5 because of the stigma attached to that kind of language. And here we see the breakdown of how alcohol use disorders are identified based on the 11 criterion described in that diagnostic manual. Oh yes, we'll come back to that. Yes, Mabel, there are quite a bit of ESPERT trainings out there, so we can hook you up with some resources if you're interested. But we see here alcohol use disorders. There are 11 criterion in that diagnostic manual, and this helps the clinician and the patient, for that matter, determine whether or not there is a presence of an alcohol use disorder along this severity scale. So if you have 2 or 3 symptoms, you would meet criteria for an alcohol use disorder mild, and subsequently up to 6 or more symptoms, meeting a severe alcohol use disorder. Alcohol use disorder is defined as a problematic pattern of alcohol use leading to significant impairment or distress. And here again, we have at least 2 of the 11 listed symptoms, and that these are occurring within a 12-month period. Symptoms of alcohol use disorder, again, I think for time purposes, I don't want to, go through these specifically, but if you're working in the field and are doing evaluations, you will be familiar with these 11 criteria. There were some changes made several years ago, but think of these first two criterion as loss of control, and can also be seen as an inability to predict when loss of control will occur. I used to say loss of control meant once a patient started drinking or using, they couldn't stop, but oftentimes it can be not knowing when that will occur. And that can be something to explore with the patient as well. I hope that makes sense. So here you see the first three, and some examples are listed in the different colored print. Craving, recurrent, and that's another thing you'll see is you'll see the word persistent. You'll see the word recurrent coming up in these criterion. So recurrent is 2 or more times. So that's important. Continued, and there's recurrent again, but each of these symptoms you would be able to address based on the information you would gather in your assessment. Now, in the screener, you may not be able to, identify a diagnosis, but we're going to talk next month about the assessment process and going through these criterion a little more closely. The 2 criterion here, these can be a little subjective, but again, watch for the word recurrent. And it's always important, to stick to the information collected at the time of the assessment. We're going to talk more about that next month, so I don't want to get hung up on a lot of assessment discussion yet, but I just wanted to give you an idea of what these 11 criterion are located in the DSM. So again, just to have an idea, we have tolerance and withdrawal. We know that withdrawal from alcohol can be life-threatening, so that's always important to keep that in mind as you're moving through an assessment of alcohol use disorders. And again, there's some noted changes here. I think this is probably a little preemptive because we'll address alcohol use disorders and the specifiers related to that next month when we talk about formal assessment. So I'm not going to spend a lot of time on those slides. So we've covered stages of change. We've covered some screening. We've covered micro-counseling. Again, I at least touched on DSM-5. I want to spend the remaining few minutes here. We've got about 20 minutes left. So yes, Matilda, we will send out a PDF version of these slides for you to utilize responsibly in your work. I want to spend a few moments before we talk a little bit about treatment options, because treatment options that discussion may come up even in the early stages of evaluation, i.e. the screener. It still may come up. So it's important to have an understanding of what different treatment options may be, particularly for the patients that you're serving and in the community that you're serving them in. So why don't we, I should be able to move through, I've got probably 5 or 6 more slides. Then we'll open the floor up for some questions, if you guys have any questions or comments. And then we should be pretty close to completing today's ESAS, but I really appreciate your time and attention on this. Let's talk just for a moment about some treatment modalities or treatment options. And you can see here, I have listed out a few things that we would want to consider. So, again, we know about the power of evidence-based treatment approaches for substance use disorders. Evidence-based is often synonymous with, people wanting to fund this or that based on the approach being supported by the scientific world. And there are pros and cons to that, because we know that evidence-based practice, those can exist even without following normal channels to conclude that something is evidence-based. But motivational interviewing or motivational enhancement therapy, cognitive behavioral, even something like 12-step approaches, there is a body of evidence. There is an evidence-based component to 12-step approaches. A lot of people think it's all anecdotal, but there has been some research done. Community reinforcement, behavioral couples therapy, pharmacological treatments. So if we're talking about anxiolytics or opioid replacement, or what they're calling now MOUD, medications for opioid use disorders, or medicated or medication assisted treatment, could be something even like using naltrexone for reduction in the use of cravings in alcohol users. Those have been around for a while. So medicated assisted treatment is, in this context, talking about opioid use, but it's been used for other drugs as well in the history of substance use disorder treatment. This is an important visual for me for understanding. If you're new to the field, I think this is really important to note as well. Ask yourself, where along this continuum of care might a screening take place? And the screening, I could see this really occurring in an ER setting or in a hospital setting. If a person is in for detox or an injury related to an alcohol use disorder or a substance use disorder, there may be a prime environment for a screener of some kind. But we can see here, this continuum of care really is on this acuity scale. So we see here, there may be an event that takes place where they're in an ER setting, and then perhaps there's a screener and an evaluation that would take place here, and then lead to a placement along this continuum. And that's when we go back to, the idea of a person being in an early stage of their substance use disorder. They may be more appropriate for, an outpatient referral or an intensive outpatient referral, rather than in an inpatient setting where they're staying, in a hospital-based or a residential facility. But we're also not even considering, psychiatric components. If they're co-occurring or comorbid issues, those would also be factored into this continuum of care. But this is in the context of substance use disorder. So I hope that makes sense. You can see the red sort of higher acuity or higher levels of care and service diminish over time, where the person may be involved in a continuing care setting or connected somehow to the recovery community through self-help groups, whatever form that may take. We know there are many pathways to recovery. So whether it's, following a traditional 12-step approach, or White Bison or Red Road, or Wellbriety, or Celebrate Recovery, or whatever it is. There are many pathways to achieving and maintaining lifestyle changes when it comes to recovery from substance use disorders. So again, evidence-based psychosocial treatment for alcohol use disorders. Again, we've talked about MI. It can be a really effective way to engage a patient in considering making changes. Again, cognitive behavioral approaches also have some real power, and there's an evidence-based component backing this, but really connecting a person's thoughts to their behaviors, connecting their emotions to how they're acting and what they're doing. This can really be powerful in a treatment setting and in treatment plan development, and help the patient make empowered, informed decisions about the lifestyle choices they're making. Again, there's some other examples here, 12-step approaches, community reinforcement approaches. This provides the patient access to community resources and personal support contingent upon, again, maintaining sobriety and other prescribed changes. And then, of course, the behavioral couples therapy, which again has a family component to it that can also be very effective in individuals in early recovery from alcohol use disorders. Again, I want to talk a little bit about pharmacological interventions. Using anxiolytics can lead to short-term reduction in alcohol consumption. So again, the use of one drug to treat another drug, there's some debate about that. There's still some pushback about substituting one drug for another when it comes to the use of things like Suboxone or Subutex or Camprol or Naltrexone or other drugs used to treat another disorder. That debate continues, but if we really apply medical model to this, if I have a patient suffering from or meeting criteria for a diabetic condition, who am I to deny the medication to treat that? The same way, if I have a patient who has an opioid use disorder, they should have the option to use another drug like Suboxone to help reduce cravings and manage and reduce their relapse or continued use potential. So I think there's a time and a place, and there's a lot of evidence that shows that pharmacological interventions for the treatment of opioid use disorders and alcohol use disorders can be very, very effective in keeping a patient engaged in treatment and reducing the chances for a return to active use. So that's just kind of a snapshot. We started off talking about screening, and this is the lead in to our discussion next month, where we're going to talk about formal assessment. So we'll probably come back and revisit some of these concepts, but I know we have about 10 minutes. Cam, is there anything in the chat that we wanted to circle back to, or is there any questions right now or comments that we could you could unmute or post them in the chat?
This is Mabel, and I just wanted to make a comment kind of highlighting when you said initially in the to engage the patient or the client. I recently attended a suicide prevention summit, but the one particular roundtable that I watched on virtual was consumers themselves. And as they shared their story, one of the takeaways that I took was one of the peers with lived experience had comorbidity, bipolar and
Yep.
substance use disorder. And so one of the things that now most of them were now professionals. Now they're on the other side providing a service, but also they're still maintaining their recovery. And so one of the takeaways that I took from the one person that spoke was that in the screening process, I guess if you're already familiar with the screening questions, it's better to memorize them or learn them, so that you can actually have a conversation with the person that's in front of you rather than not giving them eye contact and always just looking
Sure.
to your screen to input whatever the information is and making it more like rote question after question. So
Right.
that was one of the things when I thought about that when you were saying how important it is to use your active listening and attending skills.
Of course. Thank you very much, Neil. It's a great point. And I think it does go outside of the context of just substance use disorders. So I know when I was training clinicians coming into the field, I would often remind them that if a patient was in crisis or they were really struggling, it's okay to set that evaluation aside and be with them in the moment and listen and be present. And that can be very powerful response or very powerful um, presence that you can have. And sometimes it does involve setting down your agenda or your evaluation tool or your screening tool. I think there's more wiggle room in a screening to do that, whereas in a formal assessment, sometimes you're driven by time constraints, and oftentimes you have many patients that you're trying to serve in a small time frame. So, but the screening can be very informal and be very non-threatening, and there's some great examples out there of the application of SBIRT and using MI, where you're not placing an emphasis on abstinence or the discontinuation of use, but rather listening and trying to better understand the value that the patient is placing on their substance use. And again, it leads back to this idea that it may give you better insight into why the patient started using in the first place, and may also help us understand the presence or existence of any comorbid disorders that were there. There's a TAP 33 I was going to show you. I know if you go to the SAMHSA website and type in SBIRT, there are a couple of different manuals, technical manuals that are great resources. And Mabel, if you email me, I'll send you the link to our YouTube archive. We have a couple of really good SBIRT trainings on there from the past. And there are also some great examples of the implementation of SBIRT in a medical setting using MI. If you just jump onto YouTube or Google, you'll find some great examples. And I think I have some of those too that I could share with you. So SBIRT really is a great way in a non-threatening manner to engage with a patient to gather information. And in my mind, I'm ruling out rather than identifying. If I'm ruling out, then I'm making a responsible effort to identify or dismiss the presence of a substance use disorder. Yes, thank you, Kim. So yeah, feel free to reach out to me, Mabel, or anyone else if you've got some other questions. I see Frank. Frank poses an interesting question too. Frank, do you want to unmute and kind of put this out there for folks? Because I think it's a great question.
Yeah. How do I want to say this? So, 12-step programs are like AA, NA, Wellbriety, etc. But there's also 4-point programs such as SMART Recovery.
Yes.
And I am a SMART facilitator, but I'm also a Wellbriety member. And I think it's I like to hear it's like I don't view one is better than the other, and I think there's great tools to be beneficial from both of them. And I was just curious to hear your thoughts and maybe there's some other testimonials on why it's important to not focus that that one program is an answer for all.
Yes.
And I just if I could just get some feedback, that would be great.
Yeah, I'm really glad you mentioned this because I think again, I mentioned this earlier in our discussion about the many pathways to recovery. And I've always been a believer that, what works for me, it may not work for someone else. And, in the old days, it was sort of one size fits all. There were many programs, my clinic included. And when I first started working there, AA was mandated as part of the IOP experience, that if you didn't attend AA, you couldn't complete the program. And I made a concerted effort, even though I was an AA member, to dismantle that and not make it a requirement, because a person needs to explore what works for them. And I agree, whether it's smart recovery, and I think is that the one with the small book? Is that smart recovery or
Yes.
Yes, yes. And so I think that keeping yourself open to possibilities of finding what works. This field, Frank, you probably know this, the substance use disorder field used to be made up almost exclusively of people in recovery. And that's changed, over the last 20 years. There's a much broader mix of both recovery and non-recovering clinicians in the field. And I think that's added a depth and a richness to how recovery is approached. Someone in an early stage of change in an entry-level outpatient program may not be able to conceptualize or have any understanding of what long-term recovery would be, because they simply are not at a point where they're ready to consider that. So being able to shift gears and have enough flexibility and fluidity to your approaches as a facility and as a clinician is absolutely vital. If I have a young adult that wants to talk about reducing their cannabis use, then I need to be able to have that discussion with them in a respectful, responsible way. That I'm not condoning that they continue using, but I'm not demonizing it either. And it took me many years to sort of understand the importance of that. But I think that's kind of the direction you're going. If I don't mean to not answer your question directly, but I think the message I'm getting is there are many different ways to recover and make changes, and it shouldn't be a one size fits all. So that's sort of what that made me think of when you spoke about what you did in the chat. I really appreciate the question, though. Other thoughts or comments? Yep, I know we're just at the bottom of the hour, so I want to respect everybody's time. I see Cam has put the link to the survey in the chat. If you don't have time to do that today, please consider doing that when we reach out to you via email post.
I have another question.
Oh, yes. Who is that? Is that Mabel?
Mabel.
Yes.
I've heard of ASAM. I guess it's ASAM. Is that a treatment for alcohol or?
That's a great question. And ASAM stands for the American Society for Addiction Medicine. And
Okay.
it's a supplemental assessment tool that really helps the clinician determine level of care placement and progress or lack thereof throughout treatment, as well as upon discharge. It's six dimensions and has a 0 to 4 risk rating assigned to each dimension. If you email me, Mabel, I'll send you some just basic information on ASAM, but Some agencies are required to use that, and some third-party funders require that you have ASAM risk ratings when making referrals or level of care changes at the time of evaluation and or step down to a lower level of care. So that's my 30-second explanation of ASAM. But happy to share more information with you. And we'll probably do a DSM-5 ASAM training in the coming months because I know there's a big interest in that. So, but I hope that makes sense. And reach out to me via email. I'm happy to share some more information with you about ASAM. Thank you, everybody. Again, Cam, for your assistance. I didn't break Zoom, so that's always a good sign. And I want to thank everybody for dropping in and spending this past hour or so talking about the screening process. Check in with me next month. We're going to do this first Wednesday in November. We'll continue this conversation and talk more about formal evaluation in the form of assessment. So thanks again, everybody. Until next time, please stay safe, stay healthy, and most importantly, stay connected. Dokcha. So long.